everyone when you are watching this presentation. I'm sorry I cannot be there with you in person, but I'm going to use this technology and I really hope that it works. So I'm Paulin Basinga. I work for the Bill and Melinda Gates Foundation in Seattle, but this year I've been seconded back to Rwanda, where I'm originally from. So I used to work at the School of Public Health and supporting the Ministry of Health for many years before moving to the US. And as part of my PhD, I was part of a team that did the evaluation of performance-based financing program in Rwanda. So I worked with Jennifer Sturdy and other people to do this rigorous evaluation back from 2006 to 2009. So we published the first results in 2011. This presentation is covering the experience of several replications that were done after we published the first evaluation. So the outline of our presentation will do a very brief background, and then we'll describe the program in Rwanda and the first evaluation that we conducted, and then some internal validation of the data that was done, which is kind of a replication, and then the first set of other replication that other researchers did. We were also, involved in supporting them to really try to understand the program. And then the second set of replications done by other researchers using the same design that we did, but using other data source to try to replicate the results, and then also to respond to other additional questions. And then we will finish by some takeaways. Okay, for a very quick background about the Rwanda health system. So just, this graph shows you how the Rwanda health system is organized, and for the sake of this presentation, we are going only to focus on the health centers in the middle. There is one health center for each of the sector that is there, and the program that the government put in place, the performance started really at the health center level. We're going to describe that very quickly. And then how does that program was designed to be implemented? So it was really a way to incentivize health workers to produce more in terms of quantity health services, but also at the same time making sure that they produce that in an acceptable quality. So what the government did, in collaboration with some development partners, they selected some key maternal child health indicators that they were incentivizing health workers based on the quantity that they produced, but at the same time looking at the quality. So the total incentive payment was a sum of quantity indicators, but conditioning of the quality that they produced. So this is the list of key indicators. So you'll have visit and outreach, number of new visits, prenatal care services, number of women who completed for ANC, and then you see the payments that was linked to that. But here I'm going to focus on two specific indicators. The first one was facility delivery. Back in 2005 and 6, the proportion of women who were delivering at the health facility in Rwanda was pretty low, around 30%. Today, just for record, it has reached 91% in the recent DHS. But at that time, the government really put a very, it was the highest paid indicator at that time to just make sure that health facilities will, deploy strategies to bring more women to deliver the health facilities. And you see the other side is the quality of services, the scores that the government, this was a tool that the Ministry of Health was using to assess the quality quarterly, and they will come up with an indicator, with a score which was between 0 and 1, like, 80%, 30%, 50, 60%, etc. And then that quality score will be multiplied by the quantity of services that the service was provided. So that really ensures that even though you pay for the quantity, make sure that people don't just increase quantity of services, but by jeopardizing the quality. So it's really important to put the evaluation of a performance into context here. As you may remember, the dark history of Rwanda, 1994, there was a genocide, but between 1995 and 1998, the government was really doing its best to rebuild health infrastructure that was destroyed by the genocide. But after that, there was really a very strong health system that was put in place. So in 2005, this is when the performance-based financing pilot programs were kind of found to be very promising, and the government decided in 2006 to scale that. And then, but by doing that in 2006, they agreed that they are going to do it in the phased way. So the phased one will start in 2006, and then the second phase they will wait and be done. Start performance program 2008. That really gave us a very important opportunity to discuss with the government and do a randomized control trial and say, which are the districts between all the 30 districts that you'll decide to go first. So what the government, agreed is to say, let's take all the districts that started PBF before. You see the Kyangugu, Butare, and Kigali. And then when we remove them, we remove the 11 districts, we remain with 19 districts. And then we randomly select a district that will go first. And then the other district waited to go in the second phase. So we had 2 years of really doing interesting study. This is how the design came about. So those are we ended up having the pilot. Those are 11 districts. The white district that you see there, and then we ended up having 12 intervention districts. Those are the blue ones. Those are districts that started in 2006, and then they control the 7 districts. They waited. They started PBF in 2008. So we did a baseline study in all blue and yellow in 2006, and then we redid a follow-up study in 2008 before the yellow one were started the program. That really gave us a very good quasi-experimental design. We were able to tease out the real impact of incentives. So the good news was that the study allowed to be able, the government accepted to also, pay the control the average amount of money that the intervention district were receiving, but not linked to their performance. So just a bonus that they will get, so that we'll make sure that we have a very good level of finances flowing to the facilities. But the difference between the intervention and the control is that the finances that were going to the intervention district were tied to their performance compared to the control ones. So this is the design of this study. I'm not going to go into the details. You'll see that in the 19 districts, we were able to get 80 facilities in the intervention district, and 86 facilities in the control district. So we did facility surveys, we did household surveys, and then the program was really well set for an evaluation. So the main result that we are going to focus on in this presentation is the impact that we found on the institutional delivery. So we found that the pay for performance program increased significantly the proportion of women who were coming to deliver in the health facility. We'll stick into only these indicators. But before, when we saw that result, it was really very important because assisted delivery was one of the very highly paid indicator. And then it was really interesting result to see that PBF was having an impact on that particular indicator. But before we submitted the paper to publication, the main the PI of the project, Paul Gelter, really wanted to make sure that, because the result was, the analysis was being done in Rwanda in collaboration with the World Bank, so wanted to really make sure that the result was robust. So he requested one of his assistants from Berkeley University to rerun all the analysis. So we send the data, we send our codes, and he wrote, so he used the codes to just create all the data files, but he created his own code to come up with, how you define, indicators and how you run the analysis to make sure that, we checked all the errors and to assure that the analysis was replicable before we submit to the journal. And all went well, and it was he was able to replicate that, and we submitted the paper, and the paper was published in 2011 in the Lancet. It has been so far really well read and cited in several. So that was the original PBF paper that was published in 2011. Then what happened after that? I'm going now to show some of the replication study that was published after that. So Lawrence Lane was working for the World Bank in the past, and then moved to the African Development Bank, and she was doing her PhD in London, and she was interested in using the data. And as part of the agreement that the World Bank and all the researchers had with the government of Rwanda was that all the data will be public. And the team did an amazing job to really try to document all the process. So documenting, the first, memo describing the results developed in 2005, the baseline protocol submitted to the ethical committee, and then how the study was conducted, and then, put all the baseline data there, and then, documented, some of the process evaluation that was done to really try to understand how the program was being implemented, and then the follow-up study was documented, all the reports there, and then the data, all the do files, etc. Everything was made public, and people had to write a small concept note, submit to the World Bank, submit to the Ministry of Health, so that a team will agree to for the data to be used. And then after that, there was a huge capacity building component to the project that the Rwandan School of Public Health was leading with researchers from UC Berkeley. They came, ran a workshop showing people how to use the data, how to navigate through the do files using Stata. And this is part of this workshop that Lawrence Lane did analysis to really try to push the analysis a little bit further and try to see if there was a difference between different quantiles in terms of using services. So what I wanted to point out here is that when she reran the analysis, she found the same result in terms of assisted delivery. So she got what we found in the original study, and then she continued and did other analysis. So another thing, now I'm going to turn and to try to show you some of the other analysis that were done, and then another student from the US, from University of North Carolina, was interested in doing her PhD as well. So she looked at, because she was very involved in the DHS, she saw that in 2005 there was a DHS, and then 2008 there was another mini DHS that provided data just before and after the implementation of the program. So she and her team thought that that would be really a very good idea to try to replicate, to use the same design, but then replicate the result, and then try also to respond to some other questions that were not included in our original study. And one day I got an email from the team. They were interested in understanding the how the study was designed, etc. And I responded to the email. We had several conference calls, and they requested me to be part of the thesis committee for Martha, just to be able to provide them all the context, because they were based in the US. I was in Rwanda. They never been in Rwanda before, and they just wanted to really understand the context. This is how I got involved in this study. But it was really very good to see how they used DHS, which is a nationally representative data, to try to mimic the design that we did. And the good news is that they had access to the data because the DHS is public, and then also they had access to our description of the program, so they were able to match that, and they were able to try to really look at the 250 clusters that the DHS covered, and then in 2005, and then 250 clusters in 2007-8, and try to extract women and then extract some information about those women and try to mimic the study, which worked pretty well. And after doing the analysis and then matching the districts that were, you know, like where the district were located and then where the data was collected, and they rerun the analysis, and as the next slide will show you, they found that PBF increased the probability of facility delivery by 8.1%, which is pretty, you know, the same rate that we found in our analysis, which was, you know, pretty very solid to be able to show that. So one may say, because I was involved in both studies, maybe I provided a lot of information that really helped them to try to mimic the study. But in the next slide here, I'm showing you another team from Harvard. Again, Tissa Marie Sherry did her PhD as well, responding to another question related to PBF in Rwanda, the issue of multitasking. You know, try to see if, you know, providers that are being paid to respond to specific question about PBF, if they did not only focus on, you know, PBF incentivized indicator and then did not care about other indicators. So she wanted to use DHS because it was available. She did the same thing. But I knew about this study later in the process because they contacted us by email, and then we sent all the information and we pointed them to, you know, some resources that the World Bank as you know, put you know, out and in the public space. They use that, and they also replicated the same study, as you can see in the next slide, the same results, I wanted to say, in terms of you know, assisted delivery. So they found that the delivery, you know, PBF was responsible in increasing delivery by 10% point. So additional. So the main takeaway here that I wanted really to share with you is that it's really very critical to document the research very well, to make sure that when you are planning a research, you document all the process, you document all the decisions, specifically the decision that you are taking in designing the study and baseline, and then all the process, and then the end line, the dissemination, and make all the data public. Here, one critical thing I wanted to share with you is what happened is that during the early stage of the study, there was a red district. So the government decided, you know, when the team did the randomization of the program, so they randomly assigned districts into intervention control, and then the government came later and said, oh, no, wait a minute. We need to make sure that in those very few districts, during the pilot that had you know, pay for performance, if some facility were allocated to the to the phase 2, the government wanted those facilities, because of the redistricting, to be part of the phase 1. So some of the facility were changed from the interventions to you know, from the control to the intervention, to make sure that if in one specific district, all facility will be either PBF or non-PBF, because the intervention was being done at the district level. So we, you know, the team that did that, Christelle and others, really documented that very well. That helped to, you know, the other researchers to really try to replicate that. Another thing is to have clear terms of reference for data sharing, you know, and then also sharing all the code, all the do files, so that people can really track, you know, how from the original data, how you came up in this, you know, and even developing the indicators, etc. And one thing that I will also say is that even though you document, there are some institutional memories that, and then the knowledge of the context, which is key. I think it was really important to, you know, because I was in Rwanda for, you know, that time, to really try sometime, you know, to you know, provide some, you know, specific information when people don't really understand the documentation, etc. So, you know, like a phone call, even going to the countries to meet with people who were involved in the design, etc. Because you may sit in your office in the US or in the UK or anywhere else and just, you know, take everything which is online and try to replicate something without understanding everything. So I think even though you are not able to go to the country, but trying to contact the researchers who did the original study, and then try to call them and have conference calls and try really to understand all the decisions, the nuances. I think that will help. And lastly, I'll finish by saying that replication is really critical. If people can, all researchers can really think about, that there will be a replication down the road, and if that replication, provide different set of results, that will be really detrimental for the decisions and the policy implications that were done. So people are, if we can do more and more replication, I think it will really, increase the awareness of researchers to make sure that they can do a very good work in terms of, providing, a recommendation that coming, from rigorous evidence, and they will be really rigorous in terms of like their research, etc., and research implementation. So I'll end here. I don't want to spend a lot of time, and then we can, discuss later on. I'll be happy to respond to any requests by email. I'm giving you my email address, which is paulinbasinga@gmail.com. Again, thank you for your attention. I'm really sorry I cannot be there with you in person and respond to the questions, but I'll be happy to follow up with an email or with a call if anyone is interested. And also I can also share with you all the literature about Pay for Performance program in Rwanda. I wish you all the best, and thank you very much for your attention.